Hello, Nursing 222. In this lecture, we will discuss disorders and diseases of the heart. Here are your objectives for this week's content. Just take some time to read through them. And here are some more focused objectives for this week's content. So just take some time to look through them. And here are some more focused objectives for this week's content. So let's start with coronary arthro. So let's start off with coronary atherosclerosis, which is a buildup of fats, a buildup of cholesterol, and other substances within the artery walls, and they are also called plaques. And what happens is that you have these plaques build up in the artery walls, and they restrict the patient's blood flow in the arteries. These plaques can also break off and cause blood clots. Now remember, atherosclerosis can affect any artery within the body. But the good news is it can be prevented through lifestyle changes like diet and exercise, and it can also be treated with medications. Atherosclerosis happens gradually, so just over time of a patient eating a high fat diet or a high cholesterol diet, it can develop just over time. And with a mild case, there's usually no symptoms, but a patient usually starts to have symptoms when the artery starts to narrow or is clogged, and it can't supply the organs and tissues with adequate blood supply. So sometimes, and if they do develop a clot, sometimes it can either partially or completely block the patient's blood flow, or it can even break apart and cause a patient to have a heart attack, or it can travel to the brain and cause a stroke. The cause of atherosclerosis, it can be due to hypertension, hypercholesteremia, hyperlipidemia, so elevated cholesterol and lipids. If a patient smoke or use any other sources of tobacco, if a patient has diabetes, because we know that diabetes affect the arteries over time, inflammation from diseases such as arthritis or maybe lupus or any type of infection. Or if a patient just have inflammation of unknown etiology, it can also cause atherosclerosis. Symptoms are usually moderate to severe depending on how the arteries are affected. So if it's almost completely blocked, then of course you know your patient is going to have more symptoms. If the arteries within the heart are affected, then the patient will have symptoms such as chest pain or pressure in the chest. If the arteries that's leading to the brain, the coronary arteries, then the patient will have symptoms such as sudden numbness or weakness in the arms or legs. They may have difficulty speaking or slurred speech, because these are signs that there is no or there's inadequate blood flow to the brain. Or they may have drooping facial muscles, and they're just signs and symptoms of a stroke. If the arteries are in the arms or the legs and they are affected, then the patient will have signs and symptoms of peripheral artery disease. And we'll talk about that later. But they will start to have pain in the legs when they're walking. So just depending on what arteries are affected, that's where the patient's symptoms would be. If the arteries are leading to the kidneys are affected, then the patient will develop hypertension, or they can actually throw the patient in renal failure. A patient with atherosclerosis, we will attain lab tests such as your CMP, and it can help detect increased levels of cholesterol and also blood sugar that may increase the risk of developing atherosclerosis. We may do a Doppler ultrasound, which is going to measure the blood pressure in the arms and the legs. And it can help really gauge the degree of the blockage as well. And it can also gauge the speed of blood flow within the artery. So a Doppler ultrasound is something that we will use. Ankle brachial index. This test can actually tell if the patient has atherosclerosis in the arteries in the legs and the feet. The blood pressure in the ankles are compared to the blood pressure in the arms, and this is the ankle brachial index. An abnormal difference may indicate that the patient has peripheral vascular disease, which is, of course, a common cause of atherosclerosis. We may also attain a EKG, which will reveal evidence of a previous heart attack. So we want a baseline if a patient hasn't had one already. We will also obtain a stress test, which we can gather information on how well the heart works during physical exercise. We may also, or the patient may undergo a cardiac catheterization and an angiogram. And these tests can show if the coronary arteries are narrowed or blocked and the degree of that blockage. And other imaging tests, of course, they may do a CT scan or MRI, and they're just to look at the arteries more closely and look at the hardening or the narrowing of the larger vessels. So how do we treat or prevent coronary atherosclerosis? So really the key is to control the patient's cholesterol, control the diabetes or the blood sugar if a patient is diabetic, to control hypertension. So controlling these things are the key to managing the condition. So all adults 20 years and older should have a fasting lipid profile. The lipid profile contains the total cholesterol, the LDL, which is our low density lipids, and also the HDL, which is the high density lipids, and then also includes the triglycerides. With the LDL, it's considered our bad cholesterol, because what happens is if these levels are high, they actually deposit in the lining of the vessels, and it contributes to blocking the vessels. With the HDL, this is considered our good cholesterol, and this actually promotes the use of total cholesterol by transporting the LDL, the bad cholesterol, to the liver so it can break it down. The fasting lipid profile should be done every 5 years and more frequently if the patient values are abnormal. And the patients less than 20 years old with the family history, they should be treated even earlier. So it really depends on the patient history. If a patient has had an acute event such as a myocardial infarction or a heart attack, or had the procedure of CABG, which is the coronary artery bypass graft, then they should have the LDL tested within a few months of having this the heart attack or having the surgery, because the levels may be low soon after the event, so they're not really that accurate. So it should be monitored every 6 weeks until the desired levels are reached, and then every 6 months. Treating hyperlipidemia, really the goal is to have low LDLs, the bad cholesterol, and then have high HDLs, the good cholesterol. So the levels of the LDL will depend on the patient history and then also their risk factors. So that's why it's important to monitor the lipid profile. Treating hyperlipidemia, we use lifestyle changes. They're very important when treating it, such as dietary measures by eating a healthy diet, increasing physical activity at least 30 minutes a day. So take short walks, every day. Stop smoking if that's an issue, and also maintaining the patient's stress. When managing diabetes and hypertension, we want to make sure that it's really the same as diabetes management, is controlling the blood sugar, eating a healthy diet, and physical exercise as well. With hypertension, we want to make sure that the patient is taking their medication on every day as prescribed. And if a patient is on maybe medications to help with the cholesterol or diabetes, we want to make sure that they're taking those meds as well. So taking the medication, controlling glucose level, maintaining a healthy diet, and exercising, all of these things are going to help prevent atherosclerosis, or if the patient already has it, then to kind of manage it so it doesn't get worse. So let's talk about chest pain, or the medical term angina pectoris. It is chest pain caused by reduced blood flow to the heart muscle. It is really a symptom of coronary artery disease. Patient describes having or feeling pressure in their chest, or maybe heaviness or tightness, pain in their chest. It can be a reoccurring problem, or it can happen suddenly and be an acute problem. Angina is common, but it is very difficult to distinguish it from other types of chest pain, like pain or discomfort from indigestion. If a patient has unexplained chest pain, they need to seek medical attention. So we need to teach patient that if they think it's indigestion and they take something for that indigestion, and there's no relief, and the pain is getting worse and is starting to travel, then we need to teach them that that's something that they need to seek medical attention. Etiology for angina pectoris is anything that causes inefficient coronary blood flow, and it has the same risk factors as atherosclerosis. There are different types of angina. You have your stable angina, which is predictable and consistent pain that occurs on exertion and is relieved with rest, right? So just remember that stable is relieved with rest. With unstable angina, symptoms occur more frequently and last longer, and it may occur at rest. So with unstable, even if the patient is resting, they will have the chest pain. There is also intractable or refractory angina, which is really a severe type of chest pain that may incapacitate the patient, or is really debilitating severe chest pain. And then there is silent ischemia, which the patient reports no pain. There is no pain because hence the word silent. It is usually found accidentally on an EKG. So maybe the EKG was obtained for a baseline. Maybe the patient is going in for a certain type of surgery or whatever, and then they do a baseline EKG, and then they may find it on the EKG. Clinical manifestations of angina symptoms are associated. The symptoms that are associated with angina is pain that starts in the chest, maybe, and it may radiate to the arm, neck, or jaw, the shoulder or back. And the patient may also have indigestion, nausea, and vomiting. They may be fatigued or have weakness. Then they may develop shortness of breath. They may become diaphoretic and have some dizziness, because eventually it's going to start the effect of the symptoms if there's insufficient blood flow. There are many options for treatment for angina, including lifestyle changes, medication. The patient may undergo an angioplasty with stent or a coronary bypass surgery. Really, the goals to treatment are to reduce the frequency and severity of the patient's symptoms, and also to lower the patient risk of a heart attack or even death. So some of the lifestyle changes, again, it's pretty much the same as discussed previously. But if a patient has mild angina, then the patient lifestyle changes may be all that the patient needs to do. But even with the severe pain or chest pain or angina, they will still do lifestyle changes, but then they will add medications and a procedure if it's more severe. The lifestyle changes include stop smoking, making sure that the patient avoids secondhand smoke or exposure to secondhand smoke. The patient needs to lose weight. If a patient is diabetic, then they need to make sure that their diabetes are well controlled and that they're following a healthy diet and exercise plan. Because angina can be brought on by exertion, it's very helpful for the patient to pace themselves when they are exercising or moving around, and take rest breaks as needed. They need to avoid large meals. They also need to avoid stress. So whatever the patient, as a nurse, we assess what the patient usually does to relieve stress, and then we'll explore those ideas. The patient needs to eat a healthy diet with lots of whole grains, fruits, and vegetables. Limit the amount of saturated fats and those foods that are high in cholesterol, such as your fried foods. with medications, if the lifestyle changes alone doesn't help the angina, then the patient will need to take medications. And some of the medications that they would need to take is are the nitrates, which are often used to relax and widen the blood vessels, so it allows more blood flow to the heart muscle. The patient may need to take the nitrates when they engage in activity, because activity sometimes trigger angina. The most common form of nitrates you heard of, I'm sure, is nitroglycerin tablets that is administered under the patient's tongue. Aspirin is also prescribed, and it reduces the ability of the blood to clot, making it easier for the blood to flow through the narrow vessels or arteries within the heart. So it prevents blood clots, and it also reduces the patient's risk for heart attack. So what it really does is it prevents platelet aggregation. So it prevents the platelets from clumping together. They may also be on clot preventing drugs such as Plavix. You've seen that probably on your patient medication profile. And it also helps prevent clots by preventing platelet aggregation as well. So it just prevents the platelets from sticking together. The patient may also be on beta blockers, and the beta blockers is going to work by blocking the effects of the epinephrine, or also known as adrenaline. And as a result, it helps by slowing the heart rate, right? And it's causes less force, therefore reducing the patient blood pressure. And it also, beta blockers also help the blood vessels to relax, and it opens it up to help improve the patient's blood flow, which is going to reduce or prevent angina or the chest pain. The statins, statins, are drugs used to lower blood cholesterol, and it works by blocking substances that actually make the cholesterol. So this may help the patient body reabsorb cholesterol that is usually accumulated in plaques within the artery walls, and it helps prevent further blockage of the blood vessels. So a patient may be on this as well. They may also be on calcium channel blockers, which is also going to relax and widen the blood vessels by affecting the muscle cells within the artery walls, and this is going to increase the blood flow in the heart. It's going to reduce and also prevent angina. And then they may have to actually do procedures such as an angioplasty, which is going to unblock the vessels, and they may also put a stent in, which is going to clear the path so the patient can get adequate blood flow. So as a nurse, we have to teach or provide education to the patient on how to take nitroglycerin. So we want to have an educational session with the patient, sit them down when we're doing discharge teaching, so they'll understand how to take it, when to take it, how to store it, that type of thing. So with nitroglycerin tablets, the patient can take a max of 3 tablets, one every 5 minutes when they start to have chest pain. So some of the things that we need to teach the patient is that their mouth needs to be moist. They should hold saliva in their mouth until the tablet dissolves. Sometimes to get the mouth, if the mouth is dry, we can have the patient take or drink water, and this may help to moisten the mouth. We need to advise the patient to carry the tablets with them at all times, because they never know when they're going to have angina. It's unpredictable, right? They should keep the meds in a dry place and something with less moisture, because if nitroglycerin is in a moist place with heat, then it can be inactivated, which wouldn't be a good thing if a patient needs it and is no longer working. And just stress this to the patient. This is very important, to make sure they keep it in a dry place that doesn't have a lot of heat or moisture. Administer while sitting for a few minutes to avoid the patient from having syncope episodes or hypotension, because it can drop the blood pressure. The patient should have the prescription renewed every 6 months. So we need to encourage the patient for follow-up so they can make sure that they're getting their prescription fulfilled. Administer prior to exercise. When a patient knows that angina comes on with physical activity, then they may need to take a tablet before physical exercise. And it's best taken before the pain develops. So that's why it's important to stress that. Monitor the effectiveness by taking note of the time it takes for the nitroglycerin to take effect. If pain is still present after 3 tablets at 5 minutes each, then they need to seek medical care. You teach them that they do not need to continue to take the medication because something else is going on, something underlying it, and they need to be seen and have a further workup. And then we just need to monitor any side effects, or teach them how to monitor side effects, and just patient education regarding medication administration. So let's talk more about the procedures for angina pectoris. So if lifestyle changes and medications are frequently used to treat stable angina, but procedures such, like I said, like the angioplasty with stent placement, coronary artery bypass surgery, they are also used to treat it as well. So the percutaneous coronary interventions, or the PCIs, also called angioplasty with stenting. This procedure involves or improves the blood flow. It reduces or eliminates the angina altogether. With the angioplasty and stenting placement, it is a good treatment option if the patient has unstable angina, or if lifestyle changes and medications don't effectively treat the chronic stable angina, they would do these procedures as well. Coronary artery bypass surgery. This is where they take a vein or artery from somewhere else within the patient body and use it to bypass a blockage or narrow heart artery or vessels within the heart. And this bypass surgery increases the patient blood flow to the heart. It also reduces or eliminates the patient's symptom of angina. If it also is a treatment option for both unstable and stable angina that has not responded to other forms of treatment, but it does have some complications. Some of the complications would be a myocardial infarction or heart attack, or arrhythmias, because anytime you're working with the heart, you can cause further damage or cause a dysrhythmia. It can also cause hemorrhage, because heparin is given during the CABG to prevent clotting during the surgery and also after the surgery. So the patient has to be carefully monitored for hemorrhage. It can also cause renal dysfunction or renal failure, because there is a decrease in blood flow temporarily to the kidneys, and it can cause some dysfunction in the renal system. Post-procedure care. So it's similar to the care of a patient after a cardiac cath. The patient is observed for 24 hours unless it was an emergency to relieve ACS, which is acute coronary syndrome. And remember, this condition is brought on by a blockage of blood flow to the heart. So if a patient has experienced that, then they would need to go to the ICU for a few days. When the patient is in the hospital, the patient will receive heparin IV, and of course should be monitored for bleeding, as discussed, with previous disorders. They may also have or need glycoprotein, or the GP2B or 3A, which is an agent to prevent platelet aggregation and thrombus formation in the coronary arteries. And this is following the procedure of the PCI interventions. They may need this several hours following that procedure. Once the patient is stable, then labs are drawn, and then they remove the sheaths. The sheaths are put in place to prevent damage to the vessel, or also to support the puncture site during the procedure. But before the sheaths are removed, the patient is on bed rest. The head of the bed should be elevated 30 degrees or less, and the legs should remain straight. And all of this is going to prevent bleeding, right? And increase pressure in that area. When the sheath is removed, or when there's any pressure on the puncture site, it's going to cause the patient to have a vagal response, and the patient may need a bolus of IV which is going, the vagal response is going to drop the heart rate, right? And the patient may develop bradycardia. So the patient may need a bolus of IV atropine. And once the patient is stable, the patient can resume self-care and the patient can ambulate within a few hours after the procedure. And we still need to just monitor the patient for bleeding also. So it really is the same type of care after a cardiac cath. So let's briefly talk about indications and complications of cardiac surgery or surgical procedures. So really the indications for cardiac surgery is to alleviate angina, as discussed. The treatment of left main coronary artery stenosis, so when the coronary arteries are narrowed. Prevention and treatment of a myocardial infarction. The treatment of arrhythmias. Treatment of heart failure. Treatment for complications from unsuccessful PCI or the percutaneous coronary interventions, as discussed on the previous slide. So these are some of the indications for cardiac surgery. So if your patient is having any of these disorders or conditions, then the patient may be a candidate for cardiac surgery. Complications are related to the decreased cardiac output. It is also related to surgical trauma during surgery. The patient can develop hypovolemia due to the fluid shifts that occurs during the procedure. Also, due to the bleeding, they can have hypovolemia as well. They can also develop cardiac tamponade, which is where fluid and clots accumulate within the pericardial sac, which causes compression of the heart. So if a patient develops the tamponade, then it prevents the ventricles from filling. And so, of course, that's going to lead to decreased cardiac output. The patient can develop fluid overload as well because due to all the fluid and maybe blood that the patient receives during the surgery or the procedure. Patient can also have hypothermia doing this as well because they also lose a lot of blood volume. They can develop hypertension as well because sometimes they can damage the vessels, which is going to occlude the vessels even more. The patient can develop bradycardia as well, can go into cardiac failure. So anytime that you are working on the heart, the patient can develop complications from that. So it's going to throw off the rhythm, and it can also stop the heart from functioning properly. And then the patient also can develop neurological changes because when you're working on the heart, you're going to decrease the amount of blood flow to the brain as well, even if it's temporarily. And so the patient can develop neurological symptoms. So as a nurse, when a patient has undergone cardiac surgery, postoperatively, really it's the same care as for any surgical client, but the focus is on maintaining hemodynamic stability and also recovery from the general anesthesia, which is really common to any patient with a surgery. Care also focuses on pain management, monitoring cardiopulmonary status, wound care, also activity and nutrition. So pretty much the overall post-operative care of a surgical patient. Education on home care such as medication, signs and symptoms to report, incision care. Patient is usually in the hospital for 3 to 5 days or until stable, really. And this is going to vary depending on the type of surgery and complications that the patient may experience. Neurological status, of course, is the same as PERLA, level of consciousness, checking the patient reflexes, checking for facial symmetry, muscle strength in the extremities, upper and lower. So really the same neural status. Cardiac, hemodynamic status, assess the heart sounds for regular rate and rhythm, assessing if a patient has a pacemaker, of course, you will assess that and make sure it's working properly. Assessing, if they're in the ICU, we're assessing pressures, the pulmonary artery wedge pressure. Also, the patient would be on the cardiac monitor. But these pressures again are monitored as invasive blood pressure lines that the patient may have in the ICU. So if the patient is in the ICU and have these lines, then as a nurse we have to monitor the lines, paying close attention to the patient vital signs. Respiratory status, same thing, listening to the lungs, making sure that the movement of the chest is symmetrical, maintaining ventilator settings if the patient is on the ventilator, vital signs, respiratory rate, O2 stats, signs and symptoms of respiratory distress, and also attaining the ABGs and monitoring those values. We also assess peripheral vascular status, assessing the pulses, the peripheral pulses, skin color, temperature, color of the nail beds and lips, and mucous membrane. So all of that is the same head to toe assessment, assessing for edema, assessing the dressing for any drainage, also any IV sites, we're assessing that. We're also monitoring the patient labs to assess renal functioning. So we're looking at the CBC, and the CMP for the actual functioning of the kidneys, but the CBC, we're looking at the red blood cells, right? Because that's part of the renal as well. We also assessing the patient fluid balance and electrolytes. We're looking at the labs for the electrolytes, the EKG for any changes, because if the electrolytes are off, we need to look to see if there's any changes in the rhythm. Maintaining fluid, meaning assessing the patient's weight. We're also looking for edema as well when we're looking at the fluid. Managing the patient's pain, of course. Managing any equipment that the patient may have, the IV pump, the vents, any lines that the patient have. So really it's the same assessment after cardiac, just paying close attention to cardiac and respiratory. But of course, again, if the heart is not functioning properly, you're going to really paying attention to all the patient body symptoms. The nursing diagnoses that are usually pertinent would be decreased cardiac output due to the surgery, fluid volume excess, and electrolyte imbalance due to the cardiac dysfunction, impaired gas exchange due to the patient being, I guess, on the ventilator doing surgery, because it can cause atelectasis as well. Impaired cerebral circulation due to decreased oxygenation to the brain. So those are some of the ones that we can identify, for a patient with cardiac surgery. Intervention, really the focus is to restore cardiac output, to maintain adequate tissue perfusion. These are just the overall goals. Maintain body temperature, monitor and maintain potential complications, and relieve the patient pain, so pain management. So those are the overall goals that our interventions are based on. So let's talk about myocardial infarction. So we mentioned it, but let's talk more about it. It's a MI or a heart attack, and it occurs when there is a diminished or decreased blood supply to the heart, and it leads to tissue death or ischemia. It remains the leading cause of morbidity or disease and also mortality worldwide, and is the leading cause of death in the United States. Risk factors are the same as atherosclerosis. There's a blockage and there's no blood flow to the heart tissue, so therefore it dies, right? Clinical manifestations are some of the same. You will have chest pain. The patient will have a murmur when you're auscultating heart sounds. There will be jugular vein distension due to the increased blood pressure and flow. There would be elevated blood pressure, of course, because the heart is not functioning, so it's going to increase the pressure. There would be a pulse deficit. So when you're auscultating the apical pulse and feeling for the radial pulse, there will be a deficit in the numbers. Also, the EKG will show changes because the electricity of the heart will be abnormal. Diagnostic and lab tests. Echocardiogram, right? Because we need to look at the structures of the heart because there's tissue death, right? EKG, we need to look at the electricity of the heart because there will be changes. We will also obtain cardiac biomarkers. Some are very specific to cardiac, and then some just lets us know that there's muscle damage within the body. So really these markers appear in the blood after the heart has been under some type of stress. So in this case, there's tissue death within the heart. So these markers would be elevated. They include the creatinine kinase, which is the CK, and this is an enzyme that usually increases or doubles in the patient who has just had a heart attack. Because the CK can increase in many conditions besides a heart attack, it's not specific, but they will draw it anyway. The CKMB is a subtype of the CK, and this one is more sensitive for heart damage from a heart attack. So the CKMB rises 4 to 6 hours after a heart attack, but it generally goes back to normal within a day or two. So if a patient has had a mild heart attack and didn't come in, it's not really helpful for the doctor to figure out whether the patient recent chest pain was a heart attack. We will also, part of this lab draw will be a myoglobin, which is the primary oxygen carrying pigment of the muscle tissue, and it is elevated when muscle tissue is damaged, but is not specific to cardiac. So they will draw it anyway just to show that there's muscle tissue damage. Troponin, however, is released during an MI, and it is most sensitive and specific test for myocardial damage. So you will look at the troponin levels when the patient is suspected of having a heart attack or even has had a heart attack. Medical and nursing management, really the goal is to minimize the myocardial damage or damage to the heart muscle. So while the patient is being worked up for MI and the diagnosis is being confirmed, the patient will receive a combination of meds, aspirin, nitroglycerin, morphine, and a beta blocker. And then on discharge, they will be on a combination of meds as well, such as a statin, which is to lower the cholesterol, a ACE inhibitor or angiotensin receptor blocking agent, aspirin, and a beta blocker. So those would be the combination on discharge. So let's talk about each of the meds that they will be on while in the hospital. So the ACE inhibitors or the angiotensin receptor blocking agents will decrease the oxygen demand of the heart by preventing the conversion of the angiotensin 1 to the angiotensin 2, so just some A and P. But this will allow the kidneys to excrete sodium and diurese, and when this happens in turn, it's going to decrease the patient blood pressure, which is going to help the cardiac function, right? The patient would be on thrombolytics, which is going to break up clots in the coronary arteries. It's going to minimize the size of the infarction, and it's also going to preserve ventricular function, which is going to improve the heart function. And thrombolytics should be administered within 30 minutes from the time the patient arrives to the hospital or the ED. Analgesics such as the morphine will be given. It is the choice of analgesics for a MI. It is given IV to reduce the patient pain and also to reduce their anxiety. The patient will also undergo a pre-perfusion procedures, which is used to restore blood supply to the myocardium, and this includes the PCI as discussed, and the CABG, and also stent placements. Cardiac rehabilitation, once the patient is stable and free from symptoms, then cardiac rehabilitation is initiated. So here the patient receives education on risk reduction information. They will also receive individual and group support and also physical activity. It is usually done in 3 phases. In phase 1, it begins with the diagnosis of atherosclerosis. It consists of low-level activities and the initial education for both the patient and the family, and that is phase 1. And phase 2, it occurs after the patient has been discharged. It lasts about 4 to 6 weeks. Well, it lasts 4 to 6 weeks to up to 6 months, really. And it includes individualized EKG monitoring, exercise training, so the patient will receive a stress test, that's what that is, during this phase. Phase 3, it focused on maintaining cardiovascular stability and long-term conditioning, and it is self-directed. So is the patient is self-directed. So once the patient has received the education, then they can continue on, and this is phase 3. So let's talk more about the nursing management. What do we do as a nurse when a patient has been admitted with MI? So while relieving symptoms, we need to administer low-dose oxygen, usually between 2 to 4 liters a minute, via nasal cannula to help maintain oxygen saturation between 96 and 100%. This will increase the circulating oxygen to relieve the pain from the myocardial muscle. The patient should also remain in semi-phallus position, and this is going to help decrease the chest discomfort and also improve the dyspnea or shortness of breath. With improving respiratory function, of course, we need to assess respiratory function, such as listening to heart sounds. This is going to help detect early signs of pulmonary complications such as atelectasis and also pneumonia. Because when the patient has had a heart attack, they're not up and moving around, so we need to prevent respiratory complications. So again, we're monitoring vital signs, respiratory rate, O2 stats, we're listening to the lungs, and also assessing the patient for respiratory distress. We need to promote adequate tissue perfusion, so the patient should be up in the chair. And this is going to help reduce the oxygen consumption. It should be maintained until the patient is free of symptoms. So the patient can be on bed rest or they can be up in the chair. And this is going to, once they get better and the symptoms disappear, then the patient can get up and moving. But we need to continue to monitor for tissue perfusion, such as monitoring the patient's skin, monitoring perfusion pulses, and also monitoring for edema as well. We need to reduce the patient anxiety by help relieving their stress and anxiety, which will reduce the stimulation of the sympathetic response, so which will decrease the patient workload of the heart. So if we relieve their stress, they're calm, no anxiety, and we do this by educating the patient, keeping them involved in the care, explaining everything that we're doing, explaining procedures, explaining why they're having the signs and symptoms. Just keeping them well informed and educated will relieve their stress and anxiety. We need to monitor and manage any complications. So as a nurse, we closely monitor cardiac and respiratory status. So everything we just discussed or just explained, we're going to monitor those things for cardiac and respiratory, vital signs, pain management, urinary output, monitoring for EKG changes. We will know this if the patient starts reporting signs and symptoms of chest pain, of palpitation, or just feeling different. And then we're going to monitor the patient labs as well, because even if a patient just had a heart attack, they can have another heart attack. So we always monitor for signs and symptoms of a MI, even after they just had one. So we're going to move on to talking about diseases of the valves. So there's different types, different conditions that we're going to discuss. The first one we're going to discuss is mitral stenosis, which is a narrowing of the heart's mitral valve. This is the valve is abnormal and it doesn't open properly, which is going to block blood flow into the left ventricle. So if there's a blockage of blood flow to the left ventricles, then there's going to be a decrease of cardiac output to the rest of the body, right? So the main cause of mitral valve stenosis is rheumatic fever, which is related to strep infections. So that's why it's important to identify strep infections and to treat it promptly. With rheumatic fever, which is now rare in the United States, but is still common in some of your developing countries. It can cause scarring of the mitral valve, and if left untreated, the mitral valve will become stenosed and can lead to serious heart complications, of course. Clinical manifestation: the patient will have shortness of breath, pulmonary congestion because it's going to start to back up into the lung, right? fatigue. They may have atrial fibrillation. They may start to have other respiratory symptoms such as coughing. They may have hemoptysis where they're coughing up blood, palpitations, pulmonary edema, and also a murmur. So you're going to have symptoms of both cardiac and pulmonary. Because if the blood cannot flow into the ventricles, it's going to back up into the lungs. Medical and nursing management. No medicines can correct the mitral valve defect. So we use drugs that can reduce the patient's symptoms by easing the workload of the heart and also regulate the rhythm of the heart. So the patient may be on diuretics to reduce fluid accumulation within the lungs and other parts of the body. Blood thinners or anticoagulants to help prevent blood clots, because if a patient is at risk for AFib, remember AFib is going to cause clot formation because the blood is going to just sit there. They may also be on a daily dose of aspirin to help to thin the blood. They will be on beta blockers or calcium channel blockers to help slow the heart rate and also to allow the heart to feel more effectively. They may also, to prevent arrhythmias, antiarrhythmics to treat the AFib and other rhythms that the patient may develop due to the valve being stenosed. Antibiotics to help to prevent the reoccurrence of rheumatic fever if this was the cause of the stenosis. Or they may have to go in and repair with a balloon valvoplasty, which is a balloon that is inflated to widen the valve, and it's going to improve the patient blood flow. For some patient, this procedure relieves their symptoms of the stenosis and improves their condition. Or they may have to actually go in and replace the valve. And so what they do is they go in, they remove the narrow valve and replace it with like a mechanical or a tissue valve. With the mechanical valve, it may be made of metal, and they are very durable, but it can also carry risks of blood clotting. So if a patient does have a mechanical valve, you see this in the history, then you know they are also at risk for clots, and they should be on some type of anticoagulant. The mitral valve can also be prolapsed, which occurs when the mitral valve doesn't close properly, and it can cause a backflow of blood. So during the prolapse, the leaflets or the valve bulges or prolapses upward or back into the left atrium, and then the heart doesn't contract. Mitral valve prolapse sometimes lead to blood leaking backwards into the left atrium, and it causes what we call a mitral valve regurgitation. In most patients, the prolapse isn't really life-threatening, and it doesn't require treatment or changes in lifestyle. But with some people with the prolapse, it does require treatment, especially if they're having symptoms from the backflow of blood. Risk factors is usually if you're female and if you have a family history of it. And although the prolapse is usually a lifelong disorder, many people with the prolapse never have symptoms. When they are diagnosed, the patient is usually surprised that when they learn that they have a prolapse valve, because the patient just may be asymptomatic. But if they do have symptoms, it's because the blood is leaking backwards or regurgitating. And so the patient symptoms can vary from one person to the next, but they tend to be mild and they usually develop gradually. But if they do have symptoms, it'll be like a racing or irregular heart beat or arrhythmia. They may develop dizziness or lightheadedness. They may have difficulty breathing or shortness of breath. Often when they, lie flat or doing physical activity, they may be fatigued because they're not perfusing the body well if they have lots of regurgitation. The patient may also develop chest pain that is not caused by a heart attack or coronary artery disease. Most people with the prolapse, like I said, it doesn't really require treatment, but if the symptoms are debilitating and interfering with activities of daily living, of course, they will treat the patient. So if a patient has the regurgitation but do not have symptoms, then they may just suggest that the patient, return regularly for follow-up examinations or physicals just to monitor the condition. So it really just depends on the severity of the condition. However, if the symptoms are significant and there is a significant amount of blood that is leaking through the mitral valve or a significant amount of regurgitation, then the patient will be on medication or may have surgery. Medications will be used to treat the chest pain, any arrhythmias that the patient may have, and then any other complications. So some of the medications that they will be on would be beta blockers, calcium channel blockers. The patient should eliminate caffeine and alcohol because that aggravates the symptoms. They may be on a diuretic to help drain the fluid from the lungs if that's an issue. They may be on antiarrhythmic medication. And there are a few that's out there really just to control the heart rhythm. They may be on aspirin because if a patient with mitral valve prolapse has a history of stroke, then the patient may prescribe the aspirin to reduce any risk of blood clots. They may be on anticoagulants such as warfarin or Coumadin, heparin, just to prevent the blood from clotting, especially if the patient has an irregular heart rhythm like atrial fib. If a patient does have atrial fib or history of heart failure or history of strokes, then the patient will definitely be on these anticoagulation drugs. If they have to repair the valve, then the patient will they will actually go in and have the valvoplasty as discussed before. So they will go in and just, repair the valve, either with the mechanical valve or a tissue valve. So just to talk a little bit more about the different types of valves, they can have, like I said, a prosthetic one, mechanical, or the tissue valve. So if they have the mechanical valve, these here last longer. However, again, the patient will need to be on long-term anticoagulant medication such as the Coumadin for the rest of their life to help prevent the blood clots from forming around the valve. If the blood clots do form around the valve and break free, of course, it can travel to the brain and cause a stroke, or it can cause a heart attack or wherever it decides to land. With the tissue valve, they're made from animal tissue such as a pig or a cow valve. And these kind of valves can wear out over time, and the patient may also need a replacement of these valves. However, the advantage of the tissue valve is that the patient do not need to be on a long-term anticoagulant medication. So with the mechanical valve, even though they cause clots, they last longer. With the tissue valve, they have to be replaced, but they're not at risk for clots and do not have to be on the anticoagulant medication. So let's talk more about mitral valve regurgitation. It's also called mitral insufficiency or mitral incompetence. And again, is when the valve doesn't close tightly, allowing backflow or regurgitation of the blood. And of course, if that happens, again, it's not going to perfuse the rest of the body. The patient becomes fatigued and start to have respiratory symptoms as well, because the fluid is going to start to back up into the lungs. Treatment really depends on the severity of the patient condition, but if the patient just have mild leakage, then treatment may not be necessary. But if a patient does need treatment, they will have surgery to repair or replace the valve if they have severe leakage. But if left untreated, it can cause the same symptoms as the prolapse. The patient can have dysrhythmias. The patient just can go into heart failure as well. But even if the patient doesn't have symptoms, the patient still need to be evaluated evaluated with a cardiologist. Some of the symptoms, if a patient does have symptoms, they have the same symptoms as the prolapse. They what you will hear a heart murmur when you also take the heart sounds. They will have respiratory symptoms, dyspnea, especially on exertion or activity, and also they will have dyspnea when lying down. They will be fatigued during increased times of activity. They will complain of heart palpitations. They will have edema in the lower extremities, the feet, the ankles. But with mitral valve regurgitation, the symptoms are usually mild, and it usually progresses slowly. Risk factors for regurgitation include if a patient has a history of valve prolapse or stenosis, if a patient has a history of heart attack or heart disease, if a patient is using certain medications. Certain medications can actually cause it. So if a patient does have the condition, we just look at their medication profile and look to see if this is kind of like a cause of the regurgitation. If a patient has infections such as endocarditis or rheumatic fever, it puts them at risk for mitral valve regurgitation. If a patient has congenital heart disease, it can create an abnormal valve at birth. If a patient is middle age, so age plays a role, it can cause natural deterioration of the valve. So age is a risk factor. So really, the overall treatment is to just watch the patient or monitor the patient. So they need to just be monitored by their cardiologist. And remember, medications can't correct the mitral valve deformity, but it can actually help the patient's symptoms. So the diuretics can relieve the patient fluid accumulation in the lungs and in the lower extremities, and blood thinners, anticoagulants, medications to control blood pressure. So some of the same things as the prolapse as discussed, and then also surgery to replace the valve. So aortic regurgitation is similar to the mitral valve regurgitation. It's the same. It just affects the aortic valve. Some of your risk factors would be damage to the aortic valve, such as with the rheumatic fever, again, and endocarditis. If a patient has hypertension or was born with a congenital heart valve disease, that can be a risk factor. Age, of course, just over time, there's a deterioration of the aortic valve. Symptoms, if a patient does have the symptoms, it would be some of your same symptoms, right? Your respiratory symptoms, because it's not going to perfuse the body. It's going to back up into the lungs. So you have the same symptoms: respiratory distress, shortness of breath on exertion, and when laying down, you will have increased edema in the lower extremities. The patient will develop chest pain or angina, lightheadedness, fainting spells or syncope, arrhythmias. You will hear a heart murmur. They will have palpitations. So really some of the same signs and symptoms. And really the treatment of aortic valve regurgitation, again, depends on the severity of the regurgitation. Rather, the patient is observing, displaying signs and symptoms. The patient will be, of course, observed by a cardiologist to help monitor the condition, and then surgery to repair the valve. So pretty much the same, just a different valve. So this slide just talks about the types of valve prosthesis, mechanical versus tissue. I kind of got ahead of myself and already went through the differences between the two. So this slide kind of summarized what I had already discussed on the previous slides between the mechanical and the tissue. So what is our care for a patient who has just had a valve replacement? Of course, they're going to be on long-term anticoagulants, which will be initiated 48 hours after surgery. So we're teaching our patients about that. Thromboembolism is the most common complication. The patient can also have arrhythmias after the placement, infection, and hemolysis, which is the the trauma or the breakdown of the red blood cells with these valves. So we need to monitor the patient's labs. We also need to educate our patient on the importance of follow-up appointments and also coming in to have follow-up labs drawn, especially because they're on anticoagulants. We need to teach them the importance of preventing infections, such as they're at risk for infective endocarditis because of the valves. So they may need to be on prophylactic antibiotics as well. So just education, monitoring the patient for symptoms, also teaching them what symptoms to report, and it's the same symptoms, cardiac symptoms, respiratory symptoms. So we're teaching our patients to report those symptoms and when to come back. Cardiomyopathy, which is a disease or abnormal heart muscle or enlarged heart. There are three main types of cardiomyopathy. You have dilated, hypertrophic, and restrictive. Dilated is the most common type, in which all four chambers of the heart are dilated and the systolic contraction is weak. Cardiomyopathy makes it harder, of course, for the heart to pump, because if everything is enlarged, the muscles are thickened, and so it doesn't pump effectively and it doesn't deliver blood to the rest of the body, and it can lead to heart failure because it's a pump. It's going to tucker out and it's just not going to pump effectively. Cardiomyopathy can be treated. The type of treatment depends on the type that the patient has and the severity, and it may include medication, surgical implanted devices such as pacemakers, and in severe cases the patient may need a heart transplant, and hopefully it doesn't get to this point where the patient need a heart transplant, because it's not like the kidneys where you can they're more accessible, not like the kidneys. You don't have hearts just lying around waiting to be transplanted. The highest incident in the pediatric patient is usually in the first year of life. Males have a higher incident than females. In the early stages, patient with cardiomyopathy may not have symptoms, so they may be asymptomatic. But as the condition advances, the patient will display symptoms, and they include shortness of breath with exertion or even at rest. The patient will have edema in the lower extremities, the legs, the ankles, the feet. Distension of the abdomen due to the buildup of fluids. The patient will have a cough. They will be fatigued. They will have palpitations or fluttering heart sensation or beat. They will have dizziness, lightheadedness, syncope. So really the same symptoms. Diagnostic, they will actually need to look at the structures of the heart, so they would do an echocardiogram, and then they may also do a biopsy to look at the tissues as well. Medical management, the patient will be on ACE inhibitors, aldosterone antagonists, diuretics, antiarrhythmics, and also anticoagulants. So some of your same categories of drugs. Nursing management, we need to assess for signs and symptoms of heart failure, so they're the same. Cardiac monitoring, of course, the patient will be on a cardiac monitor. We need to maintain the patient bed rest, which is going to decrease the oxygen demand and decrease the work of the heart. Surgical management, if a patient they may need a heart transplant, or they may do a septal myectomy, which is an open heart operation in which the thickened, overgrown heart muscle of the septum is removed, or they remove part of the overgrown muscle, which will improve the blood flow and reduce mitral regurgitation. Myectomy is usually used if medications do not relieve the patient's symptoms. They may also do a septal ablation, which is also called a septal alcohol ablation. This treatment is used when this is when they use a small portion of the thickened heart muscle. It is destroyed by injecting alcohol through a catheter into the heart, supplying the blood. They may also need an implantable cardioverter defibrillator that may help to treat the arrhythmias, and also they may need a pacemaker as well to help the heart function properly. So let's talk more about heart failure. So all the conditions that we previously discussed can lead a patient to heart failure. So what happens, the heart muscle just doesn't pump blood as well as it should. It doesn't meet the needs of the tissues for oxygen and nutrients. Certain conditions, like we discussed previously, hypertension, coronary artery disease, or coronary atherosclerosis, it can gradually lead the heart to be weak and become stiff, and it doesn't fill and pump blood efficiently. It can be acute or it can be chronic. It is also known as congestive heart failure, or CHF, which is a syndrome in which the patient experiences symptoms of pulmonary and also peripheral congestion. So it can lead to heart failure. The types of heart failure, it can be systolic or diastolic heart failure. With systolic, it's due to a weakened heart muscle, and with diastolic, it's caused by a stiff or non-compliant heart muscle, which makes it difficult for the ventricles to fill. When a patient is in heart failure, we assess the EF or ejection fraction to determine the type of heart failure. The EF is the volume of blood ejected with each contraction of the ventricle. So a normal EF is 55 to 65% of the ventricular or the ventricle volume, and it is the hallmark sign of heart failure. So if they think the patient is in heart failure, they will assess the EF or the ejection fraction. Risk factors include hypertension. So the heart works harder than it has to if the blood pressure is too high. Coronary artery disease, because the narrow arteries may limit the patient's heart supply of oxygen-rich blood, resulting in a weakened heart muscle. If a patient had a MI or a heart attack, the damage to the heart muscle can cause the heart, it interferes with the heart's ability to pump like it should. Diabetes, which increases the patient risk of hypertension, and coronary artery disease, which in turn can cause heart failure. Certain diabetic medications like Avandia, that's one of the ones that have been found to increase the risk of heart failure in some patients. Other medications such as NSAIDs, some antiarrhythmic medications, some medications to treat hypertension or cancer. Some of these things medications can cause heart failure. Sleep apnea, the patient inability to breathe properly, can cause increased risk of dysrhythmias, which can also weaken the heart as well. Congenital heart defects, valve diseases, some viruses can cause damage to the heart muscle. Alcohol use, tobacco use, if a patient is obese. All of these things can cause heart failure. And of course, your clinical manifestation of heart failure would be the same. Of course, shortness of breath, fatigue, weakness, edema, palpitations, irregular heartbeat, reduced ability to exercise. The patient will have cough, wheezing. It just, when the heart fails, it's going to affect the entire body. The patient is going to have sudden weight gain because of the increased fluid retention. The patient, it will start to affect the GI system. They have lack of appetite, nausea, neuro effects, difficulty concentrating, decreased alertness. So it's going to start to affect all the bodies eventually. To diagnose heart failure, the patient will do a detailed medical history and review. They will review the patient's symptoms, perform a physical assessment, also assess the patient risk factors. Do they have hypertension? Do they have a history of coronary artery disease? Do they have diabetes? Do they have renal failure? All of these things, they will assess the patient risk factor. Blood tests, of course, they're going to pretty much do a detailed head-to-toe workup. They're going to check the kidneys. They're going to check the liver function. They're going to check the thyroids. Everything will be affected initially. They will also perform a chest x-ray, of course, because we need to assess the lungs, and they will get a silhouette of the heart as well to see if it's enlarged. A EKG, echocardiogram, they would do a full workup, a stress test, CT, MRI if needed. They would do a coronary angiogram to look at the coronaries, where they inject the dye. And so your care with that, if a patient is receiving dye, you got to check for iodine allergy. So pull all of that forward, and it's the same nursing care. They may also have to do a myocardial biopsy, where they just take a piece of the heart muscle to look for disease and the cause of heart failure. And your nursing assessment will focus on cardiovascular and pulmonary assessment, vital signs, including weight and orthostatic blood pressures, diagnostic tests, preparing the patient, educating the patient, medications and lifestyle changing, and education and on all of this. So when we're talking about heart failure, you will see left-sided heart failure versus right-sided heart failure. So with left-sided heart failure, the left side of the heart brings oxygen-rich blood from the lungs through the left atrium to the left ventricles, then out to the body. So when the left side of the heart is damaged or can't pump as well, it has to work harder to send blood to the rest of the body. So this causes fluid to build up in the patient's body, especially the lungs. That's why the patient has shortness of breath. It's one of the most common symptoms of heart failure. With left-sided heart failure, the patient may have systolic or diastolic failure. Systolic failure happens when the heart doesn't pump out blood the way it should, and diastolic means that the heart doesn't fill back up with the pressure as it should. Causes of left-sided heart failure is pulmonary congestion from an impaired left ventricle, or it could be caused by increase in pulmonary venous blood volume or pressure. With right-sided heart failure, the right side of the heart usually becomes weaker in response to the failure on the left side. So if you have left-sided heart failure, eventually the patient will, if left untreated, will have right-sided heart failure. And with the right side of the heart, it brings in the circulated blood from the body and sends it to the lungs for oxygen. So when the left side of the heart weakens, the right side of the heart has to work harder to compensate. Again, as the heart muscles loses strength, the blood and volume becomes backed up into the body, and the patient experiences swelling and trouble, catching their breath and shortness of breath. And some of the causes of right-sided heart failure would be if the patient has left-sided heart failure, if there's a failure of the right ventricle, and if there's increase in venous pressures as well. So eventually the left side will cause trouble with the right side. So we want to make sure that the patient, we identify it early and the patient is treated promptly. So medical management with the patient for heart failure, prevention is really the key. So the key to preventing heart failure is to reduce the patient risk factors. The patient can control or eliminate many of the risk factors of heart disease, such as hypertension, coronary artery disease, for example, by making lifestyle changes along with the help of the medication, making sure that they're taking them every day. Making lifestyle changes can often help relieve the patient's signs and symptoms of heart failure and also prevent the disease from getting worse. And the changes, the lifestyle changes are the same. Stop smoking, decrease weight, monitor the legs or the lower extremities for edema daily. Also, eating a healthy diet, restricting sodium in their diet, maintaining a healthy weight, making sure that they get their vaccination, the influenza and the pneumonia, because if that's left untreated, it can also start complications with the heart as well. Limit fats and cholesterol in the diet, limit alcohol and fluid. If the patient has an underlying heart condition or underlying condition, they may need to restrict their fluid, but not all patients. The patient needs to be active. Moderate activity or exercise help the patient to maintain a healthy weight, and also help the patient to improve their heart function. Reduce stress, making sure they get plenty of sleep. So So it just the patient can also improve their sleep by prompting up their head with pillows. So whatever works and make them feel more comfortable with breathing is going to improve their sleep as well. So just to kind of talk about the medications, if the patient is in heart failure, then the patient may be on different types of medications, a combination of medication depending on the patient's symptoms. So they would be on ACE inhibitors, angiotensin 2 receptor blockers. An example of this would be your Cozar or your Diovan. Beta blockers, they will like your low pressor, your Coreg, those type of medications. Diuretics, of course, like your Lasix. Aldosterone antagonist, this is your aldactone that you might see your patient on. Inotropes may be administered as well, and they're given, these are IV medications used in patients with severe heart failure that's in the hospital, and it improves the heart pumping function and also help to maintain the patient blood pressure. Of course, your digoxin, Lanoxin is common. You will see on your patient profile. It's referred to as digitalis, and it increases the strength of the heart muscle contraction. So it slows the heartbeat, and it reduces the symptoms of heart failure in patients with systolic heart failure. And it's most likely given in patients with, if a patient has atrial fibrillation as well. Vasodilators are used to, are given to relax the heart muscles, and the patient may also have surgery or medical devices implanted as well. They may have a CABG, coronary bypass surgery. They may have to repair their valve to make it better, or they may have to have an implantable device, defibrillators. And they may also have what we call a CRT, cardiac resensitization therapy. And this is, it sends like time electrical impulses to both the heart, or both the chambers of the atrial and the ventricles, so that it can pump more efficiently and more coordinated. So they may have this implanted as well, or they may have a heart pump, the VADs, which is a ventricular assistant devices. They are implanted in the abdomen or the chest, and is attached to the heart, the weakened heart, to help pump blood to the rest of the body. And it's most often used in patients with, is mostly used with the heart left ventricular or ventricle, but it can be used in the right ventricle or both ventricles, but usually is placed in the left ventricle. They may also just need a heart transplant or end of life heart failure. If this is the case, then the patient will be on hospice, or maybe placed, if they, like sometimes a patient will have a heart transplant and that fails. So then the patient is placed on end of life care on hospice, and then you just do palliative care from there. So let's talk more about heart transplantation. So really the indication, if a patient has end-stage cardiomyopathy, if they have complex congestive heart disease, coronary heart disease, if they have hyperplastic left heart syndrome, this is a congenital defect. So if a patient have these things, this is an indication for a heart transplant. They will be placed on the transplant list. Rejection, of course, is the major cause of mortality and morbidity in a patient that has undergone a heart transplant. Hyperlipidemia and thickening of the blood vessels are also a leading cause of death for those patients with heart transplant. Signs and symptoms of rejection is tachycardia. They will have irregular rhythm or dysrhythmia. The patient will need an endomyocardial biopsy performed in a year, then annually, to detect any type of rejection. Medications that the patient will be on would be statins to control the hyperlipidemia, calcium channel blockers to treat hypertension, and of course the immunosuppressive therapy, the same as with your renal transplants or any type of transplant. The patient should not have a live virus vaccines. They are contraindicated, of course, because it can cause the patient to go into rejection or have a infection. Education, hand hygiene to prevent infection, and adhering to the medication, because they're going to be on numerous medications, the same as with the renal transplant. After the transplant, the patient can have normal activity. They may have normal function of the heart as well. So they just have to do frequent follow-up by the cardiologist and treat symptoms as they come. So this is just a recap of the medications discussed. The nitrates, the beta-adrenergic blocking agents, calcium channel blockers, antiplatelets, the anotropics, and your diuretics. And we also talked about your ACE inhibitors. And so these are the category of meds that you need to learn and then move forward through the rest of the cardiac lectures. And here are your terms you should know. If you have an idea of what these terms mean, it can help you understand what's going on with the heart. It can help you understand your patient symptoms. It can also help you understand the patient treatment. This concludes the lecture, first half of the lecture. If you have any questions, please post it to this week's lecture discussion board. Have a great day.